Good evening, everyone. Thank you for joining us again for another webinar here. Tonight, we're going to be discussing compression neuropathies over the next hour. As you all hopefully know, you survived an entire month of April of quarantine, though none of us were in quarantine. We've covered pediatric upper extremity topics, and if you have missed any of them, you can go to the website at the bottom of the screen to get the replays. In the month of May, we have a full schedule again. We'll start with compression neuropathies. Next week, we'll do brachial plexus injuries, adult distal radius fractures, carpal instability, and then carpal fractures and dislocations. We also have a full month of pediatric orthopedic webinars. Please note and do me a favor that tonight we actually have a little change of plans. Instead of utilizing the website at the top, we're going to stay right on this platform. No one has to go anywhere. And we'll discuss pelvic and femur fractures. So please just stay on for the pediatric topic. And if you wouldn't mind maybe sending a quick email to your other residents in your program so that they're aware that we will not be on the Teams platform, but we're just going to stay right on this platform, and they can register you did and stay on this platform for the pediatric webinar tonight. That again will start right after this at 8:15 Eastern time. And you can see listed here the other topics that we'll cover for pediatric orthopedics over the next month. And we'll figure out how those other webinars will, what platform we'll be using. But for now, for tonight, we'll stay on this platform. So here are our panelists for tonight, all experts when it comes to nerve topics. To start off, we'll have anatomy and physiology from Jonathan Isaacs from VCU, then Peter Ree from the Mayo Clinic. We'll talk about anatomy and physiology of the nerve. We'll then go on to Amy Moore, who will talk about thoracic outlet syndrome, followed by Kyle Eberlin, who will talk about, Kyle Eberlin, who will talk about cubital tunnel syndrome, John Fowler, who will talk about carpal tunnel syndrome from University of Pittsburgh, ulnar tunnel syndrome will be Suhail Mathani from Duke University, and we'll finish up with Dawn Laporte from Johns Hopkins, talking about forearm compression neuropathies. So thank you to our panel of experts tonight. And again, these will be the webinars, but tonight we'll stick with the this platform for the pediatric webinars. And with that, I'm going to turn it over to Jonathan Isaacs from VCU to talk about anatomy and physiology of the nerve.
Thank you, Josh. Let me pull this up here. How's that looking? Are you seeing that?
Not yet.
Not yet.
There you go.
Very good. Thank you. Okay. So I didn't know if we needed to do disclosures, but there's my disclosures if I need those. When we talk about nerve anatomy, remember there's four components. There's the neuron or cell body, the Schwann cells, which are the quintessential support cell, obviously connective tissue that holds all the nerve elements together, and the end organs, including the motor end planes and sensory organelles. The cell body is what manufactures the neurotransmitters, essential proteins, and structural elements, and these are carried up and down the axons by a process called axoplasmic transport, which is essential to maintain the health of the nerve. Obviously, we wouldn't be talking about nerves if it wasn't that they carry signals, with the motor axons obviously carrying signals to the muscles, and the sensory axons carrying signals from the periphery back up to the central nervous system. And the way axons carry signals are through two different mechanisms. The first one is what's called a graded potential, which is basically a passive current. And the way I like to think of a passive current, it's like throwing a pebble into a pond. You throw a bigger pebble, i.e. a bigger stimuli, and you get a bigger ripple. These ripples, though, while traveling very quickly, also degrade very quickly. Now, all tissue does carry passive currents. Nerves do it a little bit better than others, but if that was the only way that they could carry signals, yes, it would carry the signals very quickly, but they would also not be able to do it very far. So the reason why nerves are able to carry signals over longer distances is because of these specialized ion pumps in the axonal membrane that create ion gradients. Remember, ions are charged, so it's so an ion gradient basically means a charge gradient, and a charge gradient is an excitable resting potential. When special voltage gated ion channels are stimulated, there's a rapid flux of these ions, which means a rapid flux of those charged particles, which results in these self-propagating action potentials. Now, the benefit is, of course, that they're self-propagating, but the downside is that they're very slow and relatively inefficient. So what the body does is it kind of combines the best of both of these mechanisms through the use of myelin. Myelin is a lipid base. Basically, think of it as an insulator that's wrapped around the axons, as you've seen drawn out there, and it's wrapped in segments so that between the segments there's little nodes of Ranvier. And at the nodes of Ranvier is where you get those action potentials. So basically, when a signal passes down the axon, you get a self-propagating action potential, very fast passive transmission of the signal, action potential, very fast passive transmission, action potential. And it almost looks like the signal is jumping from node of Ranvier to node of Ranvier, which is why it's called saltatory conduction. Saltatory is Latin for jumping or dancing. And again, myelin is essential for normal signal transmission. So you have all these myelinated axons. They're wrapped in endoneurium. All of the endoneural tubes are wrapped together as fascicles surrounded by perineurium, and all the fascicles are packaged in this kind of cushiony layer of what we call inner epineurium. Then obviously the outer epineurium surrounds the whole nerve. Now the body is able to compensate for some stresses and some compression on the nerve, and one of the mechanisms in which it does this is through this very rich blood supply that you could see up on the screen. You can imagine the axoplasmic transport, the maintaining those resting membrane potentials. All that takes a lot of energy, which means that nerves need a lot of blood, and you can see from the schematic that the body supplies them with a lot of blood. The other thing that nerves do to protect themselves a little bit is that they have that inner epineurium that I mentioned, and that inner epineurium is thicker at areas where the nerve is exposed to extra stresses or extra compression. So two mechanisms to kind of protect the nerve, but obviously we wouldn't be talking about entrapment neuropathy or compression neuropathy if those mechanisms could not be overwhelmed. And when they are overwhelmed, a couple things can happen. The first is what we call fiber deformation. If you look at the electron microscopy picture in the upper left corner, you could see that when those segments of myelin get pushed into each other from compression, it actually closes down that node of Ranvier and basically can create a conduction block by doing that. The other mechanical effect is as demonstrated by the cartoon of that guy standing on the hose, is that it blocks the axoplasmic transport again. Remember, that's essential for normal nerve function. Probably a bigger deal is the effect on the blood flow. And even though the nerves have that redundant blood flow, it can get overwhelmed. And when it does, we've all experienced low school ischemia when we sit with our legs crossed for too long and our foot falls asleep. And that's not a big deal in itself, but if it happens over and over again, like in carpal tunnel syndrome, the blood vessels inside the nerve are damaged. They start to become more permeable, which leads to vascular congestion and edema. Now the nerve is swollen, so even more prone to compression. And if this goes on long enough, you get demyelination, you get axonal loss, and you could even get fibroblast invasion and scarring of the nerve itself. So the key is to try to release the nerve before that happens. But if it has happened, if you do have some nerve damage, for example, neuropraxia, damage to that myelin, well, the nerve can and should still recover, but it can take several months. So one of the reasons why we might see somebody with several months after their nerve release getting better. If the damage is bad enough that they've had some of that axonal loss, those axons potentially can regenerate, but they regenerate at an even slower rate, about an inch a month, remember, so that if the axons have to regenerate, then you could expect the patient to take even longer to get better after that nerve release. But once they've hit that point, it creates the possibility that the muscles will change. They develop what we call denervation atrophy and lose the potential to even regain meaningful function. And a similar process occurs in the distal nerve stump, where those distal nerve stumps lose the ability to support those regenerating axons. So the take-home message from an anatomic standpoint is the key is to break the cycle before nerve damage. Once nerve damage has occurred, it can heal, but it will take a lot longer than you want. But once you hit that point, there's also the chance of irreversible damage. And with that, I'm gonna stop sharing my screen there.
Great. Thank you so much, Jonathan. Very informative and helpful. Just kick us off. So I think I misspoke earlier. Peter Reef, Mayo Clinic, is going to talk to us about physical examination of the nerve injuries and help us figure out what exactly electrodiagnostic testing is.
All right, my name is Peter Ree. I'll talk about physical exam very briefly and then spend most of the time on the basics of electrodiagnostic studies. Everyone is familiar with the MRC system for muscle strength. I just wanted to mention that M3 means that it's full active range of motion against gravity in the full range of passive motion. If it's not that, then it's not really M3. In terms of sensory exam, we're really trying to look at these mechanoreceptors in the skin, specifically the Merkel cells and the Meissner corpuscles. We can use either monofilament testing or two-point discrimination, whether it's static or moving, to look at these different mechanoreceptors. And basically, what it's trying to tell us is the number of functional sensory receptors in the fingertips where there's the highest concentration of these mechanoreceptors. It's a good tool to use, but the problem is it can be normal and mild to moderate compressive neuropathy. The Snell's, I think everyone knows what that is. Worth mentioning that as you do your serial exam, you should start to see this Snell's location march down the region of the nerve that's regenerating. If it stops at any point and it doesn't move, then it may mean that there's perineural scarring, blocking conduction, or maybe even a neuroma, incontinuity or neuroma there. Electrodiagnostic studies, it tells us a lot of things. The blue things here are what I specifically look for in this test. Now, a nerve at rest is a net negative potential. Whatever stimulus that the nerve gets, it goes beyond a threshold, an action potential is generated. In an unmyelinated axon or neuron, that conduction is pretty slow. In a myelinated nerve, it's very fast because of the saltatory conduction. In nerve conduction studies, one component of the electrodiagnostic study, and there's a lot of things that we can look at to help us make our best decision. For sensory and mixed nerve conduction studies, we're really looking for the speed of conduction and the size of that response. So when a nerve is stimulated with a probe proximally on the nerve here in red, a recording electrode further down or sensor is picking up that nerve action potential as it comes there. An onset latency means it's the very first fastest axon that reaches the finish line, where the peak latency is where most of the neurons are sending their action potentials. The amplitude means how many functioning axons are there in that action potential. It's a summated response. The duration means that how close together the different neurons are sending their impulse across. And then from there, you can also calculate a conduction velocity. This can be very helpful in trying to differentiate a demyelinating process or axonal loss. In demyelination, which is what a compressive focal neuropathy is, the axons are fine. It's just the fact that you're losing myelin. And so your conduction velocity is much slower. So your nerve action potential is the same height and amplitude because axons are fine. It's just it takes longer, so it's just a longer duration. On the opposite side, in an axonal loss, the myelin's fine. And so the axons that are perfectly healthy, they're generating a perfectly normal conduction velocity. It's just that there's some axons that are degenerating or non-functional. Because of that, the amplitude goes down. When you look at conduction velocity for motor nerves, we're really looking at the compound motor action potential. Now, the difference here is that you're stimulating on the nerve, but recording at the muscle. So that means that you're accounting for the transmission across the motor end plate. And so that's why you have to get two different measurements at two different lengths, and then subtract what would have been accounted for the transmission at the neuromuscular junction. And that's how you can get a distal latency, same amplitude, same duration. You can still get the conduction velocity off of these motor nerves. Now, if you do an inching study across a nerve and there is a sharp drop at some point, that means that there's a conduction block. So it'll help you isolate where a nerve lesion probably is. An F wave, without going into too much detail about it, everyone has an F wave. It's a normal response to stimulating a nerve, recording at the muscle. If it's absent or prolonged, it may mean that there is a more proximal lesion, as you would see in a severe radiculopathy. EMG is the other component of an electrodiagnostic study, and here you can get a lot of information. What we're looking at is the motor unit, which is essentially the anterior horn cell nerve body, the axons, and the muscles that single motor axon or that axon fires. Insertional activity is when you first put that needle into the muscle. What's the status of that muscle? If there's increased insertion activity, that means that that muscle is hyperexcitable, which is typically seen in a denervation type of process. Now, once the baseline noise goes down to normal, we look for spontaneous activities, two of which are fibrillation potentials and positive sharp waves. They're shown here. Those are pathologic to indicate that there's a degenerating nerve there. So if those are there, there's some sort of denervation. And that can be graded on the severity of those spontaneous activities. A motor unit action potential, or MUP, is really assessing a single motor axon and all the muscle fibers that that single axon fires that's recorded at the tip of an electrode. This is helpful to find denervation, because when a nerve is denervated and the conduction is much, much slower, the MUP starts to separate out, because nerves are conducting, some are fast, some are slow, and they get split up. Now, if that nerve is gone, another nearby nerve can start to sprout collaterally. And that's why a single motor axon can have more muscle fibers. And so then you'll see a larger amplitude MUP, but because these are unmyelinated sprouts, it's spread out longer in time, so it's a longer duration. Similarly, if the nerve is regenerating or there's renervation from a nerve transfer or nerve repair, those neurons are not reaching the finish line at the same time. So that's why you also see the small polyphasic, small amplitude potential, which is called a nascent potential, which is indicative of ongoing renervation. It's a good thing. And then we look at the rate and firing of the muscles. Basically, how many muscle fibers are you recruiting with a slight effort or maximal effort? Turns and phases, if you see those, that's indicative of sprouting, which is typically what you would see for denervation of a nerve. And if you put an EMG needle into a paraspinal muscle, and that's abnormal on any of these EMG parameters, that may mean that there's a radiculopathy or a root level lesion, because that's coming off of the dorsal rami, which is innervating the paraspinals. So the take-home points are, your physical exam, make sure they're thorough, and do serial exams of both sensation and motor. Know how to interpret and know what you're looking at when you order these electrodiagnostic studies. And lastly, probably most importantly, electrodiagnostic studies are just a tool. So you have to really base your decision on the physical exam, on what the patient actually does. Thank you very much.
Great.
Right.
Thank you, Peter.
I was throwing my voice, guys, so don't be alarmed.
I could speak all the panelists and think that you're an amazing ventriloquist.
For sure, Peter.
All right, so we're going to move on to Chairwoman Amy Moore, Chairwoman of Plastic Surgery at Ohio State, who's going to talk to us about thoracic outlet syndrome.
All right. All right, good evening. It's an honor to be here. Josh, thanks so much for organizing. I'm going to talk about thoracic outlet. I'm going to start my clock so I stay on time. I have a few disclosures, but nothing relevant for tonight's talk. But if we start with a definition, thoracic outlet is a constellation of symptoms and signs that are resultant from compression of the neurovascular bundle coming out of the neck. The majority are going to be neurogenic in origin, and a much lesser extent is vascular, with venous being more common than arterial compression. The epidemiology, it's rare, but I think it's just underdiagnosed and underreported, much more so than it being 1 to 2% of the population. But anywhere in the younger mid-adult range, and women are more commonly affected than men. When we think about TOS, we have to focus on the anatomy because it is here where your physical exam can help rule out other etiologies. And honestly, if I were to make anything as a take-home point, is to say that TOS is a diagnosis of exclusion. And so when we think about breaking down the anatomy to a supraclavicular, retroclavicular, and then in the pec minor space, that's where you can focus your exam, as well as trying to identify other possible sources for the numbness and tingling that your patient reports. Etiology, there could be the bony up to 30% of the case, but majority is soft tissue. We like to talk about the cervical rib, but honestly, that is very rare. And usually it's not the cervical rib that's causing the problem. There's a study that showed that if it was more related to trauma, and that if you had a cervical rib, the trauma can lead to a higher diagnosis of TOS. But again, we have to rule out things that are bad. Fractures, I would argue, are one of the most common reasons I see patients with TOS, and I think it's the increasing of swelling, the scar tissue, increased callus that narrows that space of the thoracic outlet. And so we need to be thinking from a standpoint of operating of where the etiology is, and that can help distinguish what kind of procedure you're going to perform. From the people who are coming to my clinic, I think poor posture. I have to tighten my abs and sit my shoulders back when I'm thinking about this, because the patients who come in with their shoulders rotated in, their hypertrophy of their upper traps, these are the women who are sitting in front of desks. They'll have these really overdeveloped upper traps, but weakness of the middle and lower trap. And that alone can lead to symptomatology, numbness, weakness into the hands. Overhead athletes, they're also at risk because, again, of this overdevelopment of the scalenes and the muscle of the shoulder. In the children population that I see, or the adolescent, I think it's that they've grown so fast, and then they're putting all of these movements that have just made an imbalance, and therefore symptoms are created. So what are the symptoms that people complain about? Weakness, numbness, tingling into the entire hand. There is a higher likelihood that they're going to demonstrate signs and symptoms of the ulnar 2 digits, the ring and small finger, but they also complain of pain that radiates up into the neck, onto the chest, and upper back. And so these are the patients who've seen multiple doctors, and they've come to me or to you asking, okay, I'm not crazy, I have this pain, but everything else has been normal. This is in contrast to the patients with vascular TOS. If your patient's complaining that their hands go pale when they're elevated or they turn blue and mottled, you have to be thinking, okay, this is unlikely to be neurogenic and more to be a vascular etiology. Some of the exam findings, these are the tests that are most known for TOS, and honestly, I'll just draw your attention to the 2 pictures at the bottom. The Ruse test I find is to be the most sensitive, in the sense of that you put their shoulders up and externally rotate out to try to put compression on the outlet itself. This also presses upon your pec minor, and they have to develop symptoms within 3 to 4 minutes. They usually develop within a minute if they're positive. Assessing their posture, knowing their atrophy, making sure they're symmetric from side to side is also really important. And most importantly, again, it's looking at for other diagnoses that could be explaining the symptoms. Upton and McConis talk about the double crush, where you could have something at the neck, but really their symptoms are coming from compression at the elbow or at the wrist, which you'll hear about. And so I always look for distal entrapments. I will offer surgeries on these distal entrapments before I would go to the neck, as I do think that should be saved for extreme circumstances. Imaging studies, you get your radiographs, you're going to also get the EMG and nerve conduction study that Dr. Ree talked about, but honestly, those are going to be normal. It is rare in these patients that they're going to have a positive test. And again, it's going to be rare. We're going to see that cervical rib and so forth. But again, these are options to use. If you're looking for a tumor that you don't want to miss of the brachial plexus, an MRI will help. I always send my patients to get tested with scaling blocks and pec minor blocks, and these are usually just with lidocaine. There was a study by Loom in the Journal of Vascular Surgery that showed improvement surgical improvement if they had positive effects from a block, meaning the block took away their symptoms. They would be more likely to have successful surgery. I don't know if I really believe it, but it makes me feel better that I've gone through these metrics to see. I had a couple of patients who've gotten Botox in their scalings and they didn't see me for 6 months. And so that too is an option to be using. No matter what, my patients get physical therapy, 6 weeks at a minimum. Unfortunately, many of these patients, you're like the third or the fourth doctor and they've been through a year or more of therapy. But I have a key therapist who focuses purely on TOS. And once they fail with her or with that type of intervention, then I would consider a surgical intervention. Surgery, again, this should be a last resort in the sense of trying to help these patients without any other etiology. Scalenectomy with or without the first rib resection is most commonly performed. And a pec minor release, I feel, is also very effective with low morbidity. A couple of studies have come out that showed therapy can also be very effective. And so again, 6 weeks of therapy should be tried with all patients before surgical intervention. And knowing that if you do intervene, it's not 100% with doing the scalenectomies and that hypertrophy and getting rid of the scaling muscles, but it can very much help. And I think that if you go with a careful approach to these patients, you're going to have the best results. So in summary, this is a diagnosis of exclusion. You need to rule out other bad things. Knowing your anatomy is key, being able to distinguish between different possibilities of their symptoms. Physical therapy and then surgical intervention can be successful in the right patients that you've adequately worked up. So with that, thank you so much, and we appreciate the opportunity to be here.
Great. Thank you, Amy.
Thanks.
Very difficult diagnosis at times and treatment options. So we're going to continue to work our way from proximal to distal. We're going to go to the elbow and have Hal Eberlin from MGH talk to us about cubital tunnel syndrome.
Thank you very much, Josh, and thanks for the opportunity to participate. This is a great panel. And I think this talk segues very well into Amy's discussion about thoracic outlet, because there are patients in whom have been diagnosed with cubital tunnel syndrome that actually do, in fact, have thoracic outlet. And only when their cubital tunnel surgery is unsuccessful is that figured out. So I'll be talking about cubital tunnel syndrome in 10 minutes, which is not an easy task. Here are my disclosures. So patients that present with cubital tunnel syndrome often have pain, numbness, and weakness. Pain is commonly at the medial aspect of the elbow. It also is typical in the ulnar side of the hand, particularly the distal aspect of the small and ring fingers. And numbness also follows that anatomic distribution. And I think it's useful to ask about numbness in the dorsal ulnar sensory nerve distribution. This will dovetail with Dr. Mathani's talk about Guillen's canal compression, but that's useful to know. And knowing about weakness in the hand or upper extremity is also a good idea, because if someone has intrinsic weakness from cubital tunnel syndrome, that will factor into your decision making. And very often these symptoms can be non-specific, and patients can present with variations in all three of these domains. If patients present with middle finger symptoms, it still could be from cubital tunnel syndrome or ulnar nerve compression. It's worthwhile knowing that there is a small communicating branch called the Berrettini branch between the ulnar and median nerves in the palm, which you can see here. This is from a study we published in JHS Go, but the point here is that a patient with cubital tunnel syndrome can have middle finger symptoms, and this is why, is this communicating branch. The evaluation of these patients most importantly involves a careful history, and I really think this is probably the most critical aspect of the workup. I want to know what are the exacerbating factors. Typical questions that I'll ask a patient is it worse when you're brushing your teeth or combing your hair or talking on the phone, times where your elbow is flexed? You also want to know how impactful it is from a functional perspective, and also if it wakes them up from sleep. So the history is really, really important for these patients. I also think that physical examination, to do it precisely, is worthwhile. I won't belabor the point, but getting a good sensory and motor examination, as has been already discussed, is critical. And the elbow flexion test I find to be very useful. Having a Tinel sign or absence of the Tinel sign is useful. And I do not personally use the scratch collapse test, but it has been well described, and many excellent surgeons use that in their practice. More and more for cubital tunnel syndrome in particular, ultrasound, intra-office ultrasound is very helpful, not only to help with the diagnosis, but to show patients what is going on and to talk them through their options. And Dr. Fowler, who's going to follow me, has published extensively on this. So I won't say much more than that. And lastly, we've talked about electrodiagnostics. They're very important for me for patients with cubital tunnel syndrome. When they are positive or they demonstrate pathology of the ulnar nerve at the elbow, that is very useful in helping to guide treatment. But a lot of patients with cubital tunnel syndrome will have negative EMGs, and it's a little bit more difficult to decide what to do with those patients. Here is a video of an ultrasound near the elbow. This is the ulnar nerve here, I'm pointing that out. This is the medial epicondyle, and you can see with elbow flexion that ulnar nerve subluxes over the medial epicondyle, and this is useful to see in the office. This paper we wrote a few years ago, but has useful images. So when we talk about cubital tunnel syndrome and talk about ulnar nerve compression at the elbow, there are multiple sites of compression. You have the arcatus struthers and the triceps. The arcatus struthers is about 8 centimeters proximal to the medial epicondyle. That can be a point of compression. The medial intermuscular septum is very important if you're transposing the nerve. You, in my opinion, must resect that to prevent undue compression of the nerve at that site. The medial epicondyle can also be a source. And the most common location is the cubital tunnel, is Osborne's ligament in the cubital tunnel. Patients can also have an Anconius epitrochlearis, which happens about 11% of the time as a cause. And I think also distally, the deep flexor pronator aponeurosis and the flexor carpi ulnaris are very common sites of compression. And I really focus on this when I'm doing a decompressive operation. So patients with cubital tunnel syndrome and ulnar nerve pathology are much more heterogeneous than those with carpal tunnel syndrome. And I really try to figure out and think about what is the etiology of their dysfunction. Is it compression of the nerve? Is it too much mobility? Is the nerve perching or subluxing? Is the nerve being stretched? Or lastly, is there some sort of inflammatory process going on? And very often it's a combination of these factors. This video was shared with me by Fraser Leversedge, a good friend and an excellent surgeon. I'd like to point out right here, you're going to see the ulnar nerve sublux in about a millisecond, right here, boom. And you can see the ulnar nerve perch. And if we look at the second video on the other side of the screen, watch what happens with the wrist when you get that perching of the ulnar nerve. You can see the flexion of the wrist, that's the FCU firing. That demonstrates irritability of the ulnar nerve. So in this patient, the mobility of the nerve is an issue. There are multiple classification systems. The McGowan system was described in the 1950s. There's stage 1, 2, and 3, where you have primarily subjective symptoms, and you move on to having atrophy, which is stage 3. Lee-Dellon is a classification which is also very useful. It's separated into mild, moderate, and severe, and as you can see, uses sensory motor components as well as certain testing parameters. And I'm not going to get into this in too much detail, but there are multiple classification systems. So we're all surgeons here, so the question is, what should we do surgically for these patients? And the first thing I would say is that most often, it is worthwhile attempting to treat patients non-operatively. You can provide elbow extension splints, and very often we go slowly with these patients before bringing them to surgery. Now, if you're going to do surgery and you've exhausted non-operative options, you have multiple options. You can do in situ decompression. That's typically release of Osborne's ligament and a variable amount of decompression proximally and distally. There are endoscopic techniques. There are subcutaneous and submuscular transpositions. And we could debate for about an hour or even longer than that on which technique is the best. But there are some rationale for doing one or the other. So an in situ release is less trauma to the nerve, so less surgery, of course. You inherently maintain extrinsic perfusion to the nerve, but you may not alleviate tension on the nerve itself. When you're transposing the nerve, you're lengthening the nerve, you're moving it to a new bed, but there are downsides of that also. You can disrupt the extrinsic blood supply and you may cause new sites of compression. Our best data, and I'm going to go through this really fast in the interest of time, there are multiple studies evaluating this. And there are 4 prospective randomized trials that have been published that I'll show very briefly. And there is a large trial going on now that Kevin Chung is running, and a lot of the other panelists are involved in this study that hopefully will give us more information. So very, very briefly, their study in Journal of Hand Surgery European in 2005, about 60 patients comparing subcutaneous transposition to in situ release. The bottom line is, with all the parameters evaluated, there was no difference in situ versus subcutaneous transposition. Another study, Journal of Neurosurgery 2005, about 70 patients, all of whom had severe compression. This was comparing in situ versus submuscular transposition. And there was no difference in outcomes in these patients as well. So equivalence of in situ versus submuscular transposition. A third prospective randomized study in neurosurgery. This was a larger study, 152 patients. There was no differences in outcomes between the groups, with the exception of a higher complication rate in the transposition group. And the authors wrote, because the intervention is simpler and associated with fewer complications, we advise simple decompression. Fourth study, 44 patients, similar outcome, no difference between transposition and in situ decompression. So there have been a number of meta-analyses. The first one was published by Lee Dellon in the late 1980s. A slightly more contemporary meta-analysis with more sophisticated statistical methodology was published in 2008. And overall, they did not find any difference between in situ decompression and transposition, although they did identify a trend toward improved outcome with transposition. And you can see in this forest plot here that there is a slight trend toward benefit of transposition, but not statistically significant. Lastly, I will say that expert opinion does matter. So Dr. Jupiter, who's my mentor, as well as I know Dr. McKinnon, I believe, transposes everybody. So despite the data that I presented, there are still surgeons who are experienced, very thoughtful, who transpose every single patient. So we really don't know the answer just yet. So I will say my algorithm, and then I'm going to wrap up, is that I usually will do an in situ decompression unless there is any evidence of subluxation or perching, and in which case I will do a subcutaneous transposition with an adipofascial flap. This is another image, thankfully, from Fraser, but you need a larger incision than this, and you do not want to have this zigzag deformity. This is very, very critical to avoid. You can see the circuitous nature of the ulnar nerve. So let me show you just a few slides about how I do this technique. This was described by Mel Rosenwasser in 2014. And I really like this. I think it works well. And in my hands, it's been my best technique. So here's a patient. Here's the ulnar nerve. You can see the bulbous swelling here. And I'm going to perform a transposition because the nerve is perching and subluxing. I'm going to dissect between the superficial fat plane here and the deeper fat plane. It's very easy to separate that. And I'm going to mobilize this entire adipofascial flap. You have to be careful of the MABC branches. You transpose the nerve here. And then I really use this entire adipofascial flap to cover over the nerve, and I secure it to the medial epicondyle to maintain the transposed position. My last slide here, for redo cubital tunnel decompression, you need to evaluate for MABC neuroma. You need to address that zigzag deformity. Very often you're transposing these patients. Hemostasis is critical. You do not want to stretch the nerve too much. And if you're going to use a wrap, make sure you do not put it on too tightly, and be very mindful of the epineurium. So that's 10 minutes of cubital tunnel syndrome. Thank you very much for your time and attention. And I'm going to turn it over to Dr. Fowler.
Great, excellent job. Thank you, Kyle. So John Fowler is going to talk to us about carpal tunnel syndrome from somewhere near Pittsburgh.
Thanks, Josh. Well, what is carpal tunnel syndrome? It might seem like an odd question when speaking to a lot of hand surgeons, but as Dr. Moore brought up, a syndrome is a constellation of signs and symptoms. And so the question becomes, how many signs and symptoms do you need, and in what combination, and are some more valuable than others? So I think we all know that carpal tunnel involves paresthesias in the median nerve distribution. There's decreased sensation. There's oftentimes nocturnal symptoms. They may have thenar weakness, and then our provocative maneuvers are going to be positive. Katz back in 1990 tried to come up with a hand diagram, which was aptly named the Katz hand diagram going forward. And what they did is they just looked at where patients had their symptoms on a drawing. You can see over there, was it pain, was it tingling, was it numbness? And they classified things as either classic, probable, possible, or unlikely. But as you can imagine, people drawing things may not be the most scientific way to do things. Brent Graham recently came up with CTS6 in 2006 in a Journal of Hand Surgery article. And you can see in the table on the right-hand side, I mean, these are really the classic symptoms of carpal tunnel. As you get more findings, you get more points. And if you had more than 12 points, you had greater than an 85% chance of having carpal tunnel syndrome in their study. We talk a lot about carpal tunnel and the prevalence. And when I was reviewing for this talk, it's really interesting to look at all the different prevalence studies. So looking at this study, which was a National Health Interview Survey in 1988, the national prevalence was only about 1.55%, a little higher in males and females. This study, they used the Katz diagrams, and they got about 390 surveys returned. And interestingly, 16% of patients would have had carpal tunnel syndrome based on the Katz diagrams alone. And even if all of the non-responders in this study did not have carpal tunnel syndrome, the lowest possible prevalence was 3.7%. So I think it's probably a lot higher than in that national survey study, but it's probably also not 16% as well. This study was published in JAMA in 1999 out of Sweden. And I always find it really interesting. If I could get like 75, 80% of my patients to return, or my people to return their surveys, I'd be ecstatic. Of those 2,466 responders, 354 of them had pain, numbness, or tingling in the median nerve distribution, and about 22,100 were asymptomatic. That was 14% of their respondents. Similar to that study we just looked at, where 16% had some type of symptoms in the median nerve distribution. Of those, they got 287 to come in for an exam, and they excluded some more, so they had 262 patients. So in that 262 patients that actually had a physical exam, Atroci and his group, which were orthopedic surgeons, said that 94 of them had clinically certain carpal tunnel. We heard about nerve conduction studies earlier, and so 35% of that group, and then 168 had uncertain carpal tunnel. And you can see that of those people with clinically certain carpal tunnel, 28 of them did not have or had negative nerve studies, and that was a 30% false negative rate. And then if you look at the other group that did not have clinical evidence of carpal tunnel syndrome, 23 of them had positive nerve studies for a false positive rate of 22%. So we'll bring this up later, but I think this really shows that sometimes if you're looking at the wrong patient population, the results of nerve conduction studies can fool you sometimes. There's a classic study by Gelberman where they actually put a pressure catheter inside the carpal tunnel. And I can't believe this got through the IRB. I'm not sure if it would anymore, but they had 15 carpal tunnel patients they brought to the OR and sedated, and 12 normal controls. And they looked at the pressure inside the carpal tunnel. When the wrist is in neutral, control carpal tunnel patients have a pressure of 2.5 millimeters of mercury. People with carpal tunnel, it's 32. And you can see what happens when you flex and extend the wrist. It goes way up in the people with carpal tunnel. And this is the reason why people at night get carpal tunnel symptoms, because they go into that flexion posture and they put a lot of pressure on the nerve. So we all know the risk factors. Some of them are controllable, some of them aren't. We really think it's probably a multifactorial disease process. It's not just one thing that gives people carpal tunnel. It's probably people that have risk factors, and then something pushes them over the edge. I think we all know the anatomy. Through the carpal tunnel runs the median nerve, the FPL, 4 FDPs and 4 FDSs. And what makes it worse? Well, we know that things like driving a car, grasping vigorously, people that operate vibrating tools or heavy equipment, and then we know sleeping with that flexed wrist posture definitely brings on the symptoms. So is carpal tunnel syndrome related to arm use? In general, probably not. It's likely more of a structural or genetic issue, but again, it's probably that at-risk population that then pushes things over the edge. There have been multiple studies showing that there is actually not a causal link between carpal tunnel syndrome and occupation, in particular typing, although in many states, Pennsylvania, where I live included, it's still considered a workers' comp problem. What about computer use? I kind of brought this up. So this is a really interesting study that I found that showed that in users versus non-users, so people that type and people that don't type, this meta-analysis actually found that typing was protective for carpal tunnel syndrome compared to not typing. So kind of some weird data there. Interesting though, when they looked at people who did type, people who typed more seemed like they got carpal tunnel more frequently than people that typed less. So it's kind of once you started typing, it seemed like it made it worse. But if you compare non-typers to typers, people that typed actually had a lower risk of carpal tunnel than those that didn't. So kind of interesting, crazy data. So how do we evaluate carpal tunnel? Dr. Ree went over this a little bit already. We're going to look for thenar atrophy. We'll look at sensory testing. We're going to test the APB, do some provocative maneuvers, and then potentially do electrodiagnostic testing. So I think we've all seen thenar atrophy. There's a good example of it right there. We know that shows up very late in the disease process and is a very bad sign for prognosis. Dr. Ree showed the sensory testing with Semmes-Weinstein and 2-point discrimination. We can test the APB. Really want to make sure that that thumb motion is perpendicular to finger motion. So it's going to come out of the palm, and that's how we're going to test thumb abduction. Here's an example of Phelan's test. All these tests you actually have to hold for a relatively long time. Classically, it was described as more than 60 seconds, and that would cause numbness and tingling in the median nerve distribution. Importantly, not pain, but really numbness and tingling. You can see the sensitivity and specificity data right there. The Tinel sign, again, it has to go into the median nerve distribution. I get a lot of patients that have retrograde symptoms. They'll say that the tingling or the Tinel sign runs up to the elbow or to the shoulder. That would not be a positive Tinel sign. It has to go distally. And then kind of my personal favorite, Durkin's compression test, where you push directly on the median nerve at the carpal tunnel. Now, this was the most sensitive and specific in Durkin's study. That's not been quite as high in some future studies. The recent AAOS guidelines really note that when you use any one of these physical exam maneuvers in isolation, they're not very good. When you start combining them together, they get much better. So if you have a positive Phelan, a positive Tinel, and a positive compression test, that's obviously going to make your accuracy a lot higher. We can do confirmatory testing, and I won't belabor this point because Dr. Ree went over this kind of in detail, use different cutoff values for positive diagnosis. And Dr. Eberlin mentioned this as well. I mean, one of my real passions is ultrasound. And as Dr. Isaac showed in his imaging, when you get that compression, you get swelling of the nerve due to the axoplasmic transport and also some nerve fibrosis. You can measure that swelling just proximal to the carpal tunnel, and that can give you, once you reach a certain threshold of cross-sectional area, that can be positive for carpal tunnel syndrome. We did a meta-analysis back in 2011, which showed that basically the sensitivity and specificity of ultrasound and nerve conduction studies are about the same. And then we followed it up with a cost-effectiveness analysis in 2013, which showed it's actually probably better off to get the ultrasound first. And if your results are discordant, meaning that your ultrasound doesn't match what you think it was or should be, then you should order the nerve tests. Whereas if you just get the nerve test first, it's actually more expensive in the long run. So how do you prevent carpal tunnel? Well, we talked about those risk factors earlier. So you can try to control the things that you can control. So you can try to control diabetes, control rheumatoid arthritis, correct hypothyroid. But activity modification, it's really hard. Sometimes trying to, ergonomics, we get these evaluations. Does that really help people that type a lot prevent carpal tunnel? It's really unclear. What about treatment? We'll go through some of the options: splinting, NSAID, steroid injections. Wrist splints, most people say that you should try those first for mild and moderate carpal tunnel syndrome. It's only at night. Wear them for 3 to 6 months. There's some studies that show if you wear this for 6 to 9 months, that you actually decrease the symptoms of carpal tunnel. You can try a steroid injection. One of the classic studies, David Green out of Journal of Hand Surgery in 1980. One of the really interesting things, if you got good relief from the injection versus no relief. So the good relief group, 94% of people did well with surgery. And the group that did not do well with the injection, 18% of them did poorly. So that would kind of point to maybe the injection is a good predictor of outcomes. What happens when you inject people? Well, people 50, 60% do pretty well for the first 2 months, and then it falls off pretty quickly. And that makes sense. Most steroid injections are going to last 6 to 8 weeks. What about waiting on carpal tunnel? A lot of my patients ask me this is, should I wait? Well, I think you can probably wait up to 3 years. Look at this study here showing that if you waited greater than 36 months, so 3 years, their likelihood of getting better dropped off precipitously. Whereas if you operated before that, they did much better. What about surgery versus no surgery? There was that main lumbar spine study. Well, there was also a main carpal tunnel study as well. And you can see based on these graphs that the people that got surgery got better from a symptom severity score and a functional severity score. Here's a randomized trial, steroid injection versus decompression. And you can look at the global severity score, which is similar to that Boston carpal tunnel score, showing the group that had surgery did much better overall. So how about surgery? What are the indications? Well, failing non-op treatment or severe carpal tunnel syndrome. We got the different options: open, endoscopic, and minimal incision. We won't go through those here. I think it's dealer's choice. Most of the studies show there's no long-term differences. What about outcomes? Well, it takes about 6 weeks for most people to get fully better. Their nocturnal symptoms get better more quickly. Tingling and subjective hand numbness get better. Grip and pinch strength can take up to 10 months, and 2-point discrimination may never get back to normal, especially if they had more severe symptoms. Here's a good study looking at greater than 10 years afterwards. And I think the nice thing is that of the people that had surgery, only 2% had revision surgery in the first 10 years. If you look at who was completely or totally satisfied, almost everybody, 90 some percent. And if you look at the group where the symptoms got better, that was 95% as well. Thanks for your time.
Great. Thanks, John. Great job covering a common topic in a short period of time. So we're going to stay at the wrist level and talk about ulnar tunnel syndrome by Suhail Mathani out of Duke.
All right. Can you see me okay, Josh?
Yep, you're perfect.
Very good. Well, thank you all so much for the opportunity, and thanks, Josh, for putting this all together. Here are my disclosures. And we'll start with a little review of the anatomy of the distal ulnar tunnel. So it's a fibroosseous tunnel that contains the ulnar artery and the ulnar nerve at the level of the wrist. It's roughly 4 centimeters in length, and it extends from the distal anobrachial fascia to the fibrous arch of the hypothenar muscles. The floor is the transverse carpal ligament, and the roof is the volar carpal ligament. Radially, it's bordered by the hamate hook, and ulnarly by the pisiform, the FCU, and the abductor digiti minimi. We divide compressions of the ulnar nerve and the distal ulnar tunnel into 3 zones. So zone 1, as you can see highlighted here, is that's what's proximal to the ulnar nerve bifurcation. The deep aspects of the nerve contain the motor elements, superficial the sensory elements, and it's possible to get both motor and sensory symptoms with a compression in this zone. Zone 2 is that includes the deep motor branch after the bifurcation, and zone 3 is what includes the superficial sensory branch distal to the bifurcation. And you can see here the relative incidences of the various compressions in each of the zones. The causes can be roughly grouped by zone. Zone 1 and 2 typically have a space-occupying lesion that's often deep to the nerve, and it's most commonly a ganglion. And the next most common incidence is that of a fracture resulting in the compression. Zone 3, by contrast, in general, has different underlying causes. Thrombosis of the ulnar artery, as in hypothenar hammer, or anomalous musculature can result in compression in zone 3. There are other rarer causes that can be associated with compression in the distal ulnar tunnel, including lipoma, palmaris brevis hypertrophy, pisiform dislocations, fibrous bands, and it can, of course, be idiopathic. This is an example of a zone 2 compression provided by one of my partners, Mark Richard. And you can see a deep ganglion here compressing the deep motor branch. In non-traumatic causes of distal ulnar tunnel compression, roughly 80% of them are caused by a ganglion. This is one of my cases of a zone 2 compression of a hook of hamate fracture, and you can see the fragments excise. This is a patient that had a motor symptoms associated with a hook of hamate fracture necessitating surgical excision. And this is a zone 3 compression caused by thrombotic and aneurysmal ulnar artery at the level of the distal ulnar tunnel. So patients present with several historical features that are of value to mention, not uncommonly associated with cyclists due to the prolonged compression that you can see here. There can be a history of repetitive trauma, such as in a hypothenar hammer syndrome or an athlete who's a baseball catcher. You will potentially see hook of hamate fractures present in athletes or recreational individuals trying to play baseball or hit a golf ball out of a sand trap, which is probably my most common hook of hamate fracture patient population. The diagnosis, as Dr. Eberlin kind of mentioned, is based upon an evaluation of the sensory and motor deficits, and it can be distinguished between the cubital tunnel by the preservation of the dorsal cutaneous branch, the ulnar nerve, as the takeoff of the branch is more proximal than the distal ulnar tunnel. In your further workup on physical exam, you may see patients with a abnormal Allen's test or point tenderness over the hook of hamate. pointing towards a hamate fracture. Plain films in that setting, including a carpal tunnel view, are of value to identify a fracture, and a CT is potentially indicated if their fracture is suspected in the x-rays or non-diagnostic. If you suspect a mass such as a ganglion or a lipoma, MRI is indicated, as well as in every setting, the electrodiagnostic studies being of value for any nerve compression that we're dealing with. Treatment can be non-operative, particularly for in the setting of activities such as repetitive trauma or cycling type compression that's activity dependent. You can try with rest, non-steroidals, and splinting, but failure of these conservative management or an anatomic cause of the compression, such as ganglion or fracture, can necessitate surgical release. Generally, we'll manage the inciting cause, either a surgical excision of the ganglion mass or fracture, then a complete release of the volar carpal ligament, as well as neurolysis of all branches of the ulnar nerve, as well as release of the antebrachial fascia and the fibrous arch of the hypothenar musculature. Outcomes in general, if there's a localized cause for compression, the motor changes can improve and get better. Unfortunately, there's no comparative studies or great level 1 evidence due to the heterogeneity of the causes, but overall outcomes have been reported to be good in the literature. And these are just a couple of my partners that helped me with some cases and some the help with the slides. Thank you.
Great. Thanks, Suhail. Before we move on to our last speaker, just a reminder that the pediatric orthopedic webinar on pelvis and femur fractures is going to stay right on this platform and start at 8:15. So for those of you that need a break, certainly you could take a few-minute break and then hopefully stay here. And if you could please pass that on to your colleagues. We don't want someone sitting on the wrong platform for that webinar. So our last speaker this evening is Dawn Laporte from Johns Hopkins University, the program director there, who's going to talk to us about forearm compression neuropathies. And we can see you, Dawn.
Thank you. Thank you, Josh, for putting this together. In the remaining time, I'm going to talk about forearm compression neuropathies. Pronator syndrome is compression of the median nerve at the proximal forearm and is 100 times less common than carpal tunnel syndrome. It's most frequently caused by compression between the two heads of the pronator teres, but may also be caused by compression from a ligament of Struthers or the Lacertus fibrosus, the FDS arch, or an accessory head of the FPL. You can see in the picture here the median nerve proximal to the elbow passing under a ligament of Struthers. Ligament of Struthers is present in 1 to 2% of patients and originates from a supracondylar process, this bony process, and extends to the medial epicondyl. Here's the median nerve as it passes distal to the elbow, deep to the Lacertus fibrosus, in between the two heads of the pronator, and then more distally passing deep to the FDS arch. Patients with pronator syndrome will complain of pain at the proximal volar forearm, as well as numbness and paresthesias in the radial 3.5 digits, just like carpal tunnel syndrome, but also over the thenar eminence because the site of compression is proximal to the palmar cutaneous takeoff. The differential diagnosis includes a more proximal site of compression, but often is confused with carpal tunnel syndrome, but that can be distinguished by that numbness over the thenar eminence. On exam, the patient may have a positive Tinel's over the median nerve of the proximal forearm. The most common positive test is a pronator compression test, which results in paresthesias in a median distribution with direct pressure over the median nerve at the pronator. Symptoms may be reproduced with provocative maneuvers depending on the site of compression, and classic carpal tunnel signs should be negative, like Phelan's or Tinel's or the Durkin's test. Electrodiagnostic studies are usually normal in pronator syndrome, but may identify a more proximal site of compression. And a plain x-ray of the distal humerus will show a supracondylar process if that's present, best seen on the oblique view. First line of treatment is non-operative, and up to 70% of patients may get relief with that. If the patient, however, has persistent symptoms after 3 to 6 months, surgical decompression has been reported to have good results up to 90% of the time. The initial studies recommend decompression at all potential sites of entrapment, including the Lacertus and the pronator and the FDS arch. But more recent studies, including the one from Haggart, show good results even with more isolated decompression. AIN syndrome is also compression of the median nerve of the proximal forearm, but is characterized by motor weakness with no sensory findings. The AIN is a motor branch that comes off the median nerve 4 to 6 centimeters distal to the elbow and innervates the FPL, FDP to the index and middle finger and the pronator quadratus. The etiology of AIN syndrome can be traumatic from a supracondylar humerus fracture or associated with entrapment at the same sites we discussed for pronator syndrome, but most frequently is associated with brachial neuritis or parsonage-Turner syndrome, which is typically immune-mediated and may be associated with a viral illness. The patients will present with a weakness in an AIN distribution, and the classic finding is the inability to make a normal OK sign because of dysfunction of the FPL and the FDP to the index finger. Imaging is usually normal in AIN syndrome, but an MRI may show a mass or a nerve tumor. Electrodiagnostic studies can support the diagnosis or identify another site of compression. And differential diagnosis includes tendon rupture, and that can be evaluated through tenodesis effect if the wrist is passively extended and the thumb IP and index finger FDP flex that supports that the tendon is intact. If there's a known penetrating trauma, surgical treatment and repair is recommended right away. However, if the etiology is traction or most commonly idiopathic, observation is recommended, and the majority of these will resolve spontaneously. However, if the patient has persistent symptoms for more than 6 to 12 months, surgical decompression at all potential sites of compression is recommended, and good results have been reported. Moving on to the radial nerve, PIN syndrome is compression of the posterior interosseous nerve of the proximal forearm and is characterized by motor deficit with no sensory symptoms. There are 5 described potential sites of compression with the mnemonic FREAS. The most common site of compression is the arcade of Frege, which is the proximal supinator. The etiology can be idiopathic or maybe from a mass, most commonly a lipoma or a ganglion. It may be associated with a fracture or synovitis at the radiocapitellar joint. Differential diagnosis includes tendon rupture and can be evaluated with tenodesis effect. These patients will present with weakness of finger and thumb extension, as well as weak wrist extension with radial deviation because the ECU is out, but the ECRL innervation comes proximal to the PIN branch point. They will have no sensory deficit. Electrodiagnostic studies will show motor changes after about 4 weeks. X-rays are helpful in the event of trauma and fracture. MRI is your best study to look for a mass like you see here, and ultrasound may be helpful to evaluate the nerve. If there's a known trauma or mass, then surgical intervention is recommended early to decompress the nerve and excise the mass. But if the etiology is idiopathic, non-operative treatment is recommended initially. And if the patient does have persistent symptoms, surgical decompression at all of the potential sites of compression has been described with good results. And there are a number of different intervals at which you can safely approach the PIN. Radial tunnel syndrome is also compression of the radial nerve at the proximal forearm, but is characterized by pain with no motor or sensory symptoms, so distinct from PIN syndrome. The patient will have pain over the radial tunnel, which is 3 to 4 centimeters distal to the lateral epicondyle. The reported sites of compression are the same as we talked about for PIN syndrome. On exam, the patient will have tenderness. Lowe described the rule of 9 test, which divides the proximal forearm into these 9 zones. And if the patient is tender over 1 and 2, which is the proximal lateral forearm, that's consistent with radial tunnel syndrome. The patient will have no motor deficit, distinct from a PIN syndrome. Neurodiagnostic studies are typically normal in radial tunnel. A diagnostic lidocaine injection can help to distinguish from lateral epicondylitis, although certainly radial tunnel and lateral epicondylitis can coexist. Non-operative treatment is definitely the first recommended line of treatment, and the majority of these patients will improve with non-operative measures. Corticosteroid injection can help with the symptoms as well. However, if the patient has refractory or persistent symptoms, after 9 to 12 months, surgical decompression has been reported to have good results up to 86% of the time, with isolated radial tunnel having better results than patients who have a known associated tendinopathy or known compression neuropathy. Finally, radial sensory nerve compression is compression of the radial sensory nerve at the distal forearm. It's known as Wartenberg syndrome, which is different than Wartenberg's sign, which you see in ulnar neuropathy, also referred to as chiralgia paresthetica. The sensory nerve becomes superficial, about 9 centimeters proximal to the radial styloid, and can be compressed between the brachioradialis and the ECRL. It can be caused from a direct blow or from tight cast or tight watch band or from handcuffs. The patient will present with numbness over the dorsal radial aspect of the hand. On exam, they may have a positive Tinel's over the radial sensory nerve of the distal forearm. Symptoms are reproduced with forced pronation and often with a Finkelstein's maneuver. Diagnostic lidocaine injection can help relieve symptoms and help with differential diagnosis. The majority of these patients will improve with non-operative treatment, removing any offending agents or tight structures. However, in patients that have persistent symptoms, surgical decompression has been shown to have good results 80 to 85% of the time, and often decurvain's release can be performed at the same time if the diagnosis is not distinctly clear. So in summary, forearm compression neuropathy is much less common than carpal tunnel or cubital tunnel, but it's important to recognize the characteristic symptoms and know the potential sites of compression. If there's a known lesion, surgical decompression is recommended early. However, in the majority, non-operative treatment is the first line. And if symptoms persist, patients can undergo surgical decompression with good results. Thank you.
Awesome. Thanks, Dawn. I know that was a lot of material in a period of time, but all of those nerves are near each other, so to speak. So we're going to take a little break. I'm going to ask the nerve analyst to maybe stay on for a couple of minutes in case anyone did have any questions they wanted to type in. Certainly our panelists can answer them now. And if you guys want to take a little break, please note that we'll start back up at 8:15 with the pediatric orthopedic webinar.